So, Sherry, since you already sit down there, ask you a question first. You know, the orifices of the, especially in atherosclerotic aneurysms, the orifices of the innominate and the carotid are pretty loaded with plaque a lot of times. Both the hybrid and the standard procedures kind of avoid that by going distal with the branches. Tudor's original data showed a 25% stroke rate or some horrible thing. That's why I was stopped. So, how are you going to deal with the special considerations regarding manipulation of the orifices of these things and stroke risk?
Yeah, I think I agree with you. I'm as concerned as you are. I think one of the problems with the Tudor device and anything where you're going retrograde with large profile delivery systems is that you're going to be rubbing against these atherosclerotic lesions. The advantage of the arch graft is the manipulation at that level is fairly minimal because you're only using catheters and wires, and then a fairly low profile stent graft such as a Fluency or a Gore Viabon. I think, as I said, it's contraindicated. If you see significant occlusive disease or calcification in the proximal trunks of these vessels, I don't think you should do this kind of graft. But if they're fairly clean or mildly atheromatous, I think you can get away with the branch technique. I'm a little bit more worried about putting in fenestrated grafts, especially with the preloaded wire system, because they'll just rub across all that debris. But as Dr. Yokoy showed, again, I'm pretty impressed with the fact that maybe we don't need to use this preloaded wire or catheter to maintain alignment.
Dr. Miller.
Hi, Craig Miller from Stanford. All of us know that maternity is never in question, but paternity is suspect. And I shudder a little bit having had something to do 20 years ago with the advent of thoracic aortic stent grafting. Whether I'm the mother or the father, who knows? But I am responsible in some sense for what we've seen today. And I've got a very simple answer to you, Dr. Abraham. You refer that patient to a surgeon who can do it right with reasonable results. I didn't see anything inoperable about that patient. And as I'll state tomorrow, those who are inoperable, and there's more and more TEVAR being done, but there's fewer and fewer patients living 5 years later because we're doing things in patients who are dying of other things. It's equivalent to cohort C for the percutaneous aortic valve, and it's futile therapy. So convince me that patient's inoperable, and then maybe that's the thing to do. But the results, it's exciting, it's new, but the results, I just don't think you can justify it. Now, let me ask my question to Joe and to Terry Zerny. You both have the most wonderful platform to do it right if you can justify, and I'm not going to get into that debate, that you can't do it the traditional way or Nick's way. If you're there doing something in the ascending aorta and you're going to do a hybrid, I heard Terry say that you might come back another day and do a retrograde stent graft, but why not do it antegrade at the same time when you have so much better control of everything? Why would either one of you do a two-stage and come up from below when you have the risks, which you certainly don't when you're there anyway in the ascending aorta? Joe and then Terry.
Well, I totally agree with you. For antegrade versus retrograde stenting after that, we would do mostly almost all of our cases with an antegrade stent. Occasionally you'll get into some issues where it's a little bit difficult technically, and usually if we do a retrograde stent, it's unplanned. You know, we just get through the technical portion of the operation and we say, well, we can't really put this antegrade stent in very easily. We're going to just cease and desist and come back 2 or 3 or 4 days later and put a retrograde stent in. To be honest, there are some political issues with this operation in the hospital, and occasionally it's a primary vascular surgery patient, and they like to put him in retrograde. So, but that's not really a medical reason. Is Martin there?
Yeah. Yes, actually, for us, there are 2 reasons not to go for an antegrade way. The first one is that you lose landing zone. The issue is if you insert the stent graft via the ascending aorta, via side graft, you always you always lose at least 2 centimeters of what you have just gained by transposition. That's the first thing. And the second thing is that the majority of prostheses are built and designed for retrograde delivery. And actually, there's just one prosthesis, which is the Gore prosthesis, where I think from the design, it doesn't matter if you deploy it in a retrograde fashion because it opens up from the middle. And there are not bear springs on one side and not on the other. And these are the 2 reasons for us to remain with a retrograde approach.
I repeat, we usually do the antegrade approach.
Martin, I apologize. I called you Terry.
Never mind.
Terry's your boss.
That's true.
Terry Carell. But that I don't buy those excuses. And what's wrong with the Gore antegrade? Joe Caselli, you've been a proponent of going antegrade if you're there anyway. Do you see a reason to come back another day and buy those risks?
Regarding a synchronous or a metachronous approach, I think it's a matter of setting. Previously, when we were not, when we did not have a hybrid OR, we would have to cross half of the hospital to come to the radiology suite to insert a stent graft, because we had no ability to do it in the OR. In our current setting, we do have this ability, and this is why we perform it synchronously, routinely now.
Mm-hmm. Yeah.
Joe?
Yeah, I really hate to see political issues get in the way of the care of a patient. And, I know it's a dying breed, but the way we've solved it in my unit is I'm the vascular surgeon as well as the cardiac surgeon, so the decision's made at the time and everything's taken care of under one anesthetic.
Dr. Griep, how's your blood pressure after hearing some of these presentations?
Well, you know, when you get as old as I am, you...
It's fine. He was a radical in his time.
And, you know, a lot of these things have great potential for the future. And the present is not quite so wonderful, but we do have hopes that they will get better as time goes on.
Hey, Joe, can I just say one thing just to address Dr. Miller's comments about that? He made a remark about me finding a cardiac surgeon to do these cases. I just want to make sure that everybody's clear on this, that I don't go out trying to find cardiac surgeons to work on these patients when it's the cardiac surgeons who are contacting me. I mean, if Mark Peterson in Toronto calls me to do a case or to look at a case, Mark Pelche calls me from New Brunswick, who you train personally, or Mike Moon in Winnipeg, I can tell you that there's not many cardiac surgeons better than those surgeons in those cities, so it might be difficult for me to find that, but I will give you that maybe perhaps I could send them to Stanford.
Yeah, I think
you could send them to Baja, Oklahoma. I'm sure there's someone in Houston who would help out.
I'd back him up. There's most of these cases that are presented at the in the Cook trial are actually referred by cardiac surgery. Is there another speaker back there?
Yes, Jonathan Wheelo, Atlanta, Georgia. My question is for Dr. Griep. You had mentioned significant differences between HCA and non-HCA groups in terms of neurocognitive function post-op, and I wanted to know if that difference normalizes over time or it continues to persist into the long term. And number 2 question is, you mentioned that the safety time for circulatory arrest is about 25 to 30 minutes. And I was wondering if using a retrograde cerebral perfusion or selective antegrade perfusion does extend that safety margin and how long?
I'm sorry, your first question referred to the cognitive testing, is that correct?
Yes, if the difference persists over time or it normalizes between the 2 groups in your series.
Those figures that I showed you, those were from that particular paper, were from the late tests. We did, some of those patients were tested within a week or 2, but those results were from patients from about 2 weeks out to as long as 6 months. So we didn't have a further test at 1 year. But we did see some change in those patients that we did early tests and late tests. But I think those results probably are reasonable in terms of persistence. One of the problems is with that sort of thing, the further out you go, the more difficult it is to know what it means, because there are other changes that are going on. And I suspect if you took these same patients and tested them 2 years later, they'd probably all do worse because they're older. Many of them have atherosclerosis and so on. So there's no perfect answer in terms of when to test. But we were convinced, based on this and based on some subsequent studies that we've shown, that there are real decrements in performance. And I would remind you that in routine cardiac surgery patients and in patients with short periods of circulatory arrest, we didn't see any deterioration whatsoever. I'm sorry, the second question was...
The second question was about RCP and HCA, whether RCP can increase that safe time as an adjunct to ACP.
Well, I can give you my prejudices based on some laboratory data and some very, very minor or a very small clinical experience. There's no evidence that retrograde cerebral perfusion provides nutritive flow to the capillaries of the brain in the experimental animal. And I think that's probably true in man also. I think it can be helpful during periods of hypothermic circulatory arrest as an adjunct to cooling. But I think we've shown in the experimental animal, and I suspect it's also true in man, that you can keep the brain just as cold by packing the head in ice rather than flowing retrograde. So I'm sorry Dr. Safi isn't here. He's one of the last holdouts of retrograde cerebral perfusion to defend that point, but I don't believe it does much good. In terms of antegrade cerebral perfusion, I think that's an entirely different situation. I think antegrade cerebral perfusion is not HCA, and I suspect that you can go on for quite long intervals with antegrade cerebral perfusion. Indeed, I think in most of the clinical series that I've seen and in people that I've talked to that use a lot of antegrade cerebral perfusion, the major issue having to do with duration has to do with distal body hypothermic circulatory arrest. So, and if you're going to put a catheter in the descending aorta and do antegrade cerebral perfusion, you're basically doing cardiopulmonary bypass. So I think if you want to use very long periods of selective cerebral perfusion without distal perfusion, you have to be pretty cold. But based on our experience, with cold selective cerebral perfusion, and Dr. Boucher can speak to this, although he never went as long as we do, you can probably go for an hour and a half, maybe up to 2 hours without any difficulty.
Thank you.
Santi, Dr. Trimarchi.
Santi Trimarchi, San Donato, Milan, Italy. I have a question for Dr. Yokoi. Thank you very much for your presentation. It looks something extraordinary. You report about 400 patients. It looks very curious if we compare your results, for example, with the results from Dr. Abraham, who then use a kind of conventional branched graft. So you report about a fenestrated graft, but you don't have any side branch, if I assume it well. And I would like to know something more about what type of stent you have. It's a nitinol. Do you balloon these patients? What type of oversize you use? And what are the results that you had in terms of endoleak and the long-term results, which is your longest term follow-up? Thank you.
I'm sorry, I'm not good and so well explanation is I cannot well experiment, but I never done the branched graft because you know the many surgeons is very special technique in Japan. We must limit the embolic stroke and the complications within the open surgical repair. So the fenestrated, my investigation is very simplified and safety is the most important purpose. So the I think the stent grafting is one of the therapy for the thoracic and thoracic aortic disease. So it is aim is safe is most important, and the second is wide indication. So and the next I think so, and the next question is Byron is performed in selectively because during the deployment period we use blood pressure and spreading expanded to proximal landing zone. So and the 70% of patients don't need touch-up Browning.
So I think this is a multi-center national trial for Japan. I'm sure it'll be published pretty soon regarding, some of the details, and we'll have to wait for that information in more detail at that time. Is there someone behind Santi there? Dr. Tremaci, sir.
Yes, hi, this is George Tolis from Boston. I have a question for Dr. Spielvogel. In terms of the trifurcated graft technique, which you and Dr. Griepp taught me how to do, I have noticed that it seems to be easier to just do the subclavian artery under circ arrest and then clamp the distal stumps of the left common carotid and the brachiocephalic artery and do these under blind selective perfusion through the axillary cannula at about 10 cc's per kilogram per minute. And that seems to, that decreases the circ arrest time a fair amount. You end up having about, 8 or 10 minutes of circ arrest. The time that it takes to dissect out the arch and do the subclavian anastomosis is the hardest one to do. And then you convert the rest of the 20 minutes or whatever it is that would be normally circ arrest into blind unilateral selective perfusion. Do you think there's any problem with doing it this way? Do you think there's any drawbacks?
So David and then Joe.
Actually, George, I think that it's right on the money. I always think that the left subclavian is the most difficult to access when you're doing an arch replacement. Sometimes it's really displaced away from you. So actually, that's exactly what I do. I always do the left subclavian first. And as time has gone on, and we've gone really to the approach where you do begin perfusion unilateral and just occlude the brachiocephalic vessels, then sew the rest of the graft on. So yes, you can do it for under 10 minutes. I almost always do the left subclavian under circ arrest. It just seems easier. But certainly, yeah, absolutely.
And you can inspect the vessels and see if they're diseased, and if they are diseased, then obviously you wouldn't clamp them. But usually the distal stumps are fairly disease-free in the arches, at least in my experience.
Absolutely, I agree.
Thank you.
Joe, want to comment on that technically?
We do something quite similar. We use a trifurcation graft, and we'll go to the left subclavian while we're cooling, and then you can perfuse through the trifurcation graft into the left subclavian so that you're hitting your vertebral while you're doing the left carotid, and then you're meanwhile perfusing via the axillary artery into the right carotid, and then under circ arrest you move to the innominate artery, and then you're perfusing all three head. While you're doing the innominate, you're perfusing all the head vessels, and so it's body circulatory arrest, but your cerebral circulatory arrest is over at that point. So it really brings it down to really just a few minutes while you're doing the left carotid.
And under deep hypothermia or relative hypothermia?
We use 24 degrees centigrade. We're kind of in between some of those that are interested in the higher levels, but we've got a great deal of respect for some of the data that's come out of Randy Griepp and the group at Mount Sinai that we've arbitrarily gone about 24 degrees.
So I would assume that under deep hypothermia, you wouldn't be nervous about a circ arrest time involving the vertebral.
Certainly less so. But I also think there's a group of patients that during the cooling period, it's going to really be hard to get to that left subclavian. And so I think you need to look at the anatomic considerations. And there may be some people that a carotid subclavian bypass, to eliminate that factor. But again, that's sort of a patient selection issue.
Yeah.
Thank you.
Dr. Rosselli.
Let me add just one more thing to that. I think there's, I haven't heard it mentioned yet, but we've run into some patients that we've had large vertebral arteries coming off the transverse aortic arch and selected to maintain patency of those. And on occasion, we've reattached them to that Dacron graft that goes off to the left subclavian, but more often than not, we just reattach them to the left carotid.
Eric Roselli from Cleveland. First, I'd like to make a comment with regards to the discussion that went on earlier about Dr. Miller's comments about antegrade delivery of stent grafts. In our experience, we've had a couple patients who had some spinal cord ischemia related to extensive coverage with the antegrade delivery of stent grafts. And so we've learned, despite having cerebral spinal fluid drainage, that if we have to cover an extensive amount of thoracic aorta, it's probably best, as Dr. Griep has taught us, to break up that insult over time and do that second operation retrograde maybe 5 days or a week later. The other reason I'm here is I have a question for Dr. Yokoi about the fenestrated device. Fascinating images, but my question to you is what sort of rescue strategies do you have in place in the event that you can't get access or can't get the fenestrations lined up with those vessels? It didn't look like there were very many wires in those aortas on those images you showed.
Yeah, Dr. Yokoi.
We have 3 patients with accidental chimney stenting simultaneously. And the alignment, the rotation of the device is no problem. So it is a problem is too proximal or too distal, maybe too proximal. And then we can guide, after the deployment, we can put into from the left common carotid and into the sheath and with bared stent, chimney stenting, or any other no complications. Maybe almost no complications because we have a lot of cases.
So in the 3 patients you had to salvage, you were
Yes.
able to access the fenestrations with a stent?
Yes.
Are the fenestrations on the device custom designed for the patients?
Oh, yeah,
ahead of
every
time?
one of them, yes.
Yeah, okay.
But custom, but we have already setting and choice. So very quickly fabricated from just selecting from those types of fenestrations, so we can make a clinical trial.
Right, so there's less variations in the arch than the thoracoabdominal aortic branches. Right, thank you.
Thank you. Sir.
Jahangir Rapu here from Calgary. I have 2 questions, one for Dr. Yokoi and one for Dr. Hagel. I'm very impressed that you have a series of 350 totally endovascular arches. It's very impressive. Now, I noticed, I think 3 of them were for aortic dissection. I was wondering if these are for acute aortic dissections, and if you're moving towards using this therapy in the acute situation. And I also wanted to ask Dr. Hagel what their standard approach is for an acute type A and their indications for an elephant trunk in acute type A dissection.
Dr. Yokoi, first.
Yes, 3 patients had previously aortic dissection type A.
Chronic.
So the chronic.
Chronic, so, and just little and leaks after procedure, so we must attach a Browning, and then acute, but one patient is conservative follow-up, we can conservative follow-up, and the 2 patients to the open surgery.
Would you consider using this for an acute type A dissection?
I'm sorry?
Would you consider it in an acute type A dissection?
I think that is next problem for me.
Christian, interesting question.
I think the most important thing in a type A aortic dissection is that the patient survives. That's the first thing that you have to achieve. So you need some experience with the frozen elephant trunk, for example, to use that in a type A aortic dissection. But we start to get more and more aggressive in using it especially if you have tears in the aortic arch. If you don't have them and you open the arch, we go with a proximal arch repair. If you have tears in the distal arch, we do in frozen elephant trunk. But I have to confess, we don't know what is the perfect sizing, and we still try to figure that out.
Okay, let's see what we got here. So a couple of questions from me is the Yale group. This is for our Japanese surgeons as well as Dr. Griepe, maybe. Was posed by Dr. Caselli. We have a couple of groups, maybe one major group that uses circulatory arrest alone for all arch cases. A number of groups that use retrograde alone. Is our RCP and straight hypothermic circulatory arrest dead at this point? I noticed in the Japanese literature, Dr. Okita, that it was 10 or 15% of the surgeons still use RCP. Can you comment on that? And then maybe you can go down the panel with the arch surgeon. Is it all ACP now? Is the rest, everything else is dead, or no?
I only use very simple cases, hemiarches, for deep hypothermic circulatory arrest and retrograde cerebral perfusion.
So you use, this is important, so you use retrograde for straightforward open distal anastomosis hemiarches and ACP for all total arches.
In a selected patient, in a complicated cases or very sick patients, I always use antegrade cerebral perfusion.
Okay.
We mean hemiarch repair, because initially, in my presentation, we switched to the retrograde to the antegrade, because you have a circulatory arrest time of 40 years, 15 minutes in the retrograde cerebral perfusion with hypercirculatory arrest. We have a lot of patients with a transient neurological deficit.
Yes.
So we changed to the antegrade.
So that's Dr. Kazui's paradigm too. Circ arrest time is less than 30 minutes. Hemiarch is RCP, and everything else is ACP.
Less than that, 20.
20, okay. Dr. Ogino?
My question is a little bit different. I use this SCP to all cases. And our technique is very simple. Right axial artery cannulation and ascending of the femoral cannulation. This technique is just used for all patients, even in the aortic dissection. We call that double cannulation. Very simple. So it's quite easy. Just the clamp on the innominate artery, just the SCP is started. So basic method is SCP. Mm-hmm. Very simple.
So Joe Caselli, do you do antegrade even for 20-minute circ arrest times?
Essentially, no. We quit using retrograde years ago, just pretty much abandoned it. But since we moved to axillary and innominate artery sites for cannulation, not to use antegrade in some form or fashion, even for a short period of circulatory arrest, just is not very appealing.
So, Roberto, and this is also for the panel, if anybody wants to put in, regarding redo operations and the whole concept of LV venting, it seems that many cases, and many surgeons kind of blow that off. They don't look at it as a very important concept, whereas many of us actually feel it's very important, even to the point, like you showed, of doing a small left thoracotomy. So can you tell us about your approaches to LV venting and the redos, and what's your thoughts on that? Left ventricular venting. Because sometimes it's hard to get to anything on those big redos.
And when it's difficult, the re-entry in the sternum, and if there is the severe aortic valve insufficiencies, I think it's very important to put the vent in the left ventricle. And this technique, I think, is a very simple technique to introduce in the apex of the left ventricle a small venting. Another important things, I think, I speak during the presentation, is the isolation of innominate artery before to open the sternum. Because in this case, when you arrive in the temperature, 26, 25, 24, what you want, if you put a clamp in the innominated artery and reduce the CPB flow and come with, generally I use 800 milliliter in the left axillary artery. In this case, you have the perfusion of the cerebral right part and also generally the majority of the case also the left hemisphere, and then open the sternum.
Dr. Griepe, you were going to say something? Again, it's very difficult sometimes on these really bad redos to get into a venting anatomy.
No, I actually wanted to comment on something else.
Okay.
If that's all right. I just want to say a word about the issue of paraplegia and elephant trunks and frozen elephant trunks. You and I have talked about this, Joe, and it started out being a tremendous conundrum to me that we, in doing descending thoracic aortic open surgery, to see a spinal cord insult from a resection that's limited to the chest is almost unheard of, extremely rare. So, you know, I don't buy the concept that it's the elephant trunk occluding segmental vessels that's causing the paraplegia. I think there are basically three issues that I think need to be kept in mind if this 5% or 7% or sometimes 3% incidence of paraplegia in elephant trunks is going to be dealt with. One is, I think, perfusion of the left subclavian, or leaving the left subclavian not perfused long term. I mean, there's lots of experimental evidence and so on, and clinical series too, I think, to some, that you need the left subclavian if you're going to take out a number of segmental vessels. So that's the first reason. The second is the injury to the spinal cord by lower body circulatory arrest at warmer temperatures. That I think in many cases there's a sublethal injury that's delivered to the cord. It may be, say, only 30 minutes at 30 degrees or something like that. The cord might recover under optimal circumstances, but then on top of that, you take a patient who's had a very big, complex operation and who is probably not going to be hemodynamically stable to the same extent that your descending thoracic open case has been. Now, that patient may be intubated for a couple of days. Nobody's going to be paying attention to keeping the blood pressure up, particularly if there's a little more bleeding and so on. The blood pressure is kind of allowed to drift down. So I think you take the combination of a sublethal injury by not perfusing the cord, or particularly the lower part of the cord during selective cerebral perfusion, and then on top of that, you superimpose some instability and postoperative hemodynamics. I think those are probably the main considerations in causing spinal cord injury in these patients. And I would hope that attention to those particular issues might reduce the incidence.
Okay, I'll give the last question to Dr. Miller.
Not a question this time, Joe. It's Craig Miller. I just would like to give an answer to your point. Roberto, I agree 100%. You've got the chronic third, fourth time redos with a lot of AR. You have to open the sternum under circ arrest. You can make the little thoracotomy like you described, but for 5 or 10 years, we've just been percutaneously venting the apex with TE guidance. Remember, those of you who were at the NIH in the old days all could do an LV stick, and the PMIs are really out there, the ventricle's big. And over a wire, just put in an 18 EOPA or something like that. And then later on, when everything's, you can dissect it out and put a stitch in it. The TVAR experience, I think, has shown us that, Joe. And someday we're going to be doing percutaneous transapical TVARs, right, Joe?
You mean TAVIs?
TAVR, excuse me.
Yeah, that's right.
TAVIs. But you've done a TVAR through the apex, too. More than one.
More than one, yeah. Okay, well, with that note, thank you all for coming, and I want to remind everybody that we have the welcome reception in the exhibit hall right now. Thank you.